All right, everybody. I know you got the maternal newborn ATI is coming up next week. So I was going to post a few audio visual videos for you to listen to in regards to maternal newborn review. This particular video, we're going to talk about some of the antenatal aspects of maternal newborn nursing. I have a couple little cheat sheets for you to look at along with while I do the wait, I need to put that there. Okay, so let's brush up on some key concepts. Antepartum care refers to the care of the mother before childbirth. So you have to know knowledge of the physiological changes that accompany pregnancy and fetal development, and that's essential to understanding client care during that antepartum period. So I need you guys to make sure that you go back and review your basics of antepartum care, what different antepartum tests and procedures are available, and common antepartum disorders and complications. So the normal antepartum period is, we're looking at maternal history, physical exam, and educating client. So let's start from beginning, and that is the presumptive signs of pregnancy. Remember, we have things that where it's like presumptive or probable. So presumptive would be that you miss a period, or that you have breast enlargement or tenderness, that you're tired, that you're getting skin pigmentation, that you have some nausea and vomiting, or that you have increased urinary frequency. We have probable signs of pregnancy. And then probable signs is something called ballottement, which is talking about something to do with the coloring of the uterus or cervix. Someone could have Braxton Hicks contractions. They could have a Chadwick sign. They could have a Goodall sign. They could have a Hager sign. Make sure you look up all these terms to remember what they are. Abdominal enlargement is a probable sign of pregnancy. So a definite sign of pregnancy. All right, so also probable is a positive urine pregnancy test. A positive urine pregnancy test does not always mean the patient is pregnant. So that is a key factor. Remember, that is probable. The definitive that a person is pregnant is detection of a fetal heartbeat. And that's visible. We could probably see it around 8 weeks on ultrasound. To listen, about 17 to 20 weeks. And a lot of NCLEX questions will throw that positive urine pregnancy test in as a definitive sign, and it is not a definitive sign. Okay, so let's talk about physiological adaptations. Remember, every body system changes during pregnancy, but a big one that changes is the heart. You need to review your cardiovascular system changes. Cardiac hypertrophy, because we have increased blood volume, and increased blood volume causes increased cardiac output, which causes increased stroke volume, which makes the heart bigger. We get displacement of the heart upward and to the left because of the expanding diaphragm from the baby. And we get progressive increase in blood volume, peaks around the 3rd trimester. Our resting pulse rate fluctuates and increases about 15 to 20 minutes, 15 to 20 beats per minute when we are at term pregnancy. And just remember that pregnancy is not a disorder. So we are going to do lots of education. All right, so let's go to the next slide. All right, so things that can happen. Acquired immunodeficiency syndrome, otherwise known as AIDS. Women who have HIV can get pregnant. So you'll see questions in regards to key signs and symptoms: diarrhea, fatigue, Kaposi's sarcoma. If you ever watched the movie Philadelphia, you remember Tom Hanks had those on his arm. Mild flu-like symptoms, opportunistic infections, candida, pneumocystis carinii, herpes virus, vaginal yeast infections, oral thrush yeast infections. Looking at our test results, CD4 count, T cell count, enzyme-linked immunosorbent assay shows a positive HIV virus antibody. Western blot test is positive. HIV is tested in the first trimester, and it is tested again before delivery. They may even do, if there's someone's at risk, they might even do it during the third trimester. We have if they are newly diagnosed HIV, they will be given retroviral treatment. And we have to make sure that we're assessing whether this client can care for their infant after delivery. Adolescent pregnancy. Adolescent pregnancy is not as common as it used to be, so that is good. But key signs and symptoms can be denial of the pregnancy, which may deter an adolescent from seeking care early. Test results is, positive pregnancy tests. And then we're going to look at, because this is a risk factor, our children shouldn't be having children. So the body is not quite ready to sustain a healthy pregnancy. So when minors are having pregnancy, they do have special nutritional needs, the higher caloric needs than maybe somebody like in their later 20s. We always want to monitor their weight, and we want to make sure that they are aware of their options. Well, that's with any pregnancy. We want to make every woman aware of what her options are in the event that she had an unintended pregnancy. And we have diabetes mellitus. Key signs and symptoms is that, the polydipsia, polyphagia, glycosuria, ketonuria, polyuria, like all the things that you learned about type 2 diabetes can apply toward gestational as well. They'll do a 1-hour glucose tolerance test, and the glucose will be greater than 140. Key treatments are a lower caloric diet split between 3 meals. They do snacks. We make sure it's low fat, low cholesterol, high fiber. After the first trimester, they can start medications. We try to avoid metformin in them. Usually if a woman can't control it with diet, they'll put her on insulin. And we're going to encourage adherence to dietary regulations. We're going to encourage the client to exercise moderately. We're going to prepare the client for the antepartum fetal testing that's going to be needed, which includes oxytocin challenge, stress testing, amniotic fluid indexes. Remember, if a mom's having gestational diabetes, that baby's also being exposed to all of that high glucose. And remember, when you have high glucose, it makes your kidneys secrete more urine. So these babies actually can produce more urine, which causes more fetal fluid around the baby, because that amniotic fluid is essentially baby pee. Atopic pregnancies. They can have irregular vaginal bleeding, abdominal or pelvic pain. It can be sharp, it can be dull. Things that can happen, rupture of the tubes, sudden severe abdominal pain. They can pass out. The uterus size is smaller than expected for gestational age is a risk, like showing that there's a possibility that this baby is not in the uterus, that it's in the tube. So we want to do our HCG testing. In a normal pregnancy that is established in the uterus, the HCG will rise differently than an ectopic pregnancy. And we're also going to look at serum progesterone levels. And if there is an ectopic, we need to intervene because this can become a life-threatening emergency. So there needs to be a laparotomy. We're going to ligate the bleeding vessels. We're going to remove the fallopian tube. If the tube hasn't ruptured, they can sometimes repair it, and the person doesn't have to lose their entire tube. So we're looking at interventions. We want to make sure that the patient, we're going to check them for hypotension, tachycardia, dizziness, administer blood products if needed. And if that person is Rh negative, meaning they have O negative, A negative, B negative blood, they will be given RhoGAM because we don't know if the fetus, well, the ectopic products of conception had a positive blood type. So we're going to just assume that it had a positive blood type and that mom possibly could have made antibodies, and we just give her the RhoGAM. Right. Heart disease. Signs and symptoms of heart disease, not a lot different in pregnant population than it is in your regular population. We're looking at tachycardia, dyspnea, fatigue, diastolic murmurs at the heart's apex, crackles at the base of the lungs. Remember, if you have fluid in the lungs, what side of the heart is that? And you can always remember left for lungs, right for the right rest of the body. If there is fluid backing up in the lungs, it is left-sided heart failure. We're going to look at our echocardiograms or chest x-ray, looking for cardiac abnormalities, impaired cardiac function, any kind of decompensation. And then going over the treatments, always anticoagulants, especially if we have a electrical current issue, because we don't want to throw a clot. Person could be put on antiarrhythmics such as the DIG, beta adrenergic blockers, thiazide diuretics, furosemide, which is Lasix, can control heart failure, reduce sodium intake. We need to assess cardiovascular and respiratory status, always on our patients administering oxygen by nasal cannula or face mask during labor, positioning the client on their left side with their head and shoulders elevated during labor. Something else that you may have remembered from your maternal child nursing class is that hydatiform molar pregnancy. Sometimes you'll see it written as. That is an intermittent or continuous bright red or brownish vaginal bleeding around 12 weeks gestation. There is no fetal heart rate because this is not a baby. Our HCG levels will rise extremely high early in the pregnancy, and an ultrasound will fail to reveal a fetus. And that's usually how we can tell that this is a molar pregnancy. So it needs to go. So key treatments will be therapeutic abortion, which is a DNC, if the body hasn't expelled it on its own. And then we're going to monitor those HCG levels for multiple weeks until they remain normal. And then we're going to do periodic follow-up because there is an increased risk of cancer in women who have had a molar pregnancy. Next is hyperemesis gravidarum. If you remember, that is a woman who has extreme pregnancy, vomiting, continuous severe nausea, high risk of dehydration. Apparently that was the end of my slideshow there. They'll have oliguria. They will not be peeing because they're not bringing in any fluid. This is a medical we need to intervene. This is a very important intervention. We need to do arterial blood gases, make sure that this mom is not in metabolic alkalosis. We need to do hemoglobin levels. We need to do serum potassium levels because she's at a high risk for hypokalemia. Our key treatments will be restoration of fluids, restoration of electrolyte balances. We do not need this mother seizing or going into a cardiac arrest. We always have to monitor our fundal height to make sure that the baby's growing adequately and that the fundal height matches the week's gestation that she is. We need to provide her small, frequent meals. And most of the time, these women will end up on IV fluid replacement and total parenteral nutrition. Remember, there's PPN and TPN. Partial parental can go through a standard peripheral IV line. Total parenteral nutrition has to go through a central line, either a PIC or some other kind of central line, because the dextrose content cannot go into that venous system through a peripheral line. Other things to make sure you look up for antenatal diseases is hypertensive disorders of pregnancy, looking up your gestational hypertension, right? That's onset of hypertension without protein after 20 weeks gestation. Preeclampsia is hypertension plus the protein in the urine. And then there are 3 categories of preeclampsia: mild and severe. And then the third is eclampsia. So mild preeclampsia, we're looking at blood pressures 140/90. We're going to have about 300 milligrams of protein in the urine in the 24 hours. In severe, blood pressure is going to be 160/110, 5 grams of protein in 24 hours in the urine. And if they are producing less than 500 mLs of urine in 24 hours, they'll have visual disturbances, right upper quadrant tenderness, fetal growth restriction. If we have high blood pressure, think about it, the blood is not flowing to the baby is not going to be able to grow. And then we have eclampsia, and that the difference between pre and eclampsia is the onset of the seizure activity. So we're going to have presence of new onset grand mal seizures in a client with preeclampsia. Then there are patients who have chronic hypertension. This is not gestational hypertension. These people had hypertension prior to getting pregnant. Gestational hypertension will resolve within 12 weeks of delivery. The only cure for gestational hypertension is deliverance of the baby. A chronic hypertensive patient, they'll still have high blood pressure after the baby is born. So you're going to look also at blood chemistry, blood, the BUN, the creatinine, your uric acid levels, and your liver enzymes. Things we can do when someone's hypertensive, put them in left lateral position. If they have mild preeclampsia, they will probably induce the mother to have the baby when the baby reaches a mature gestational age. If the patient is severe, chances are they're going to take that baby early. One of the things you'll see hung a lot is magnesium sulfate. Make sure you look up magnesium sulfate, know why it's used in gestational hypertension, and know what you need to do as a nurse, what assessments you need to do when your patient is on magnesium sulfate. All right, so we use it mainly to reduce the amount of that acetylcholine that produces by the motor nerves, and then that lowers our seizure threshold. But it can also cause catatonia, so we need to make sure that you are doing those deep tendon reflexes. So I'm going to assess clients for edema, protein in their urine, maintaining seizure precautions, left lateral recumbent position, monitoring their blood pressure, being prepared to obtain a blood sample for type and cross match if this is going to be an emergency delivery. Always keep your antidote to mag sulfate on you if that is your patient. And do you guys remember what the antidote is? Calcium gluconate. That is a key one. I've seen NCLEX questions with that. Calcium gluconate for the administration at the first signs that we have mag toxicity. So we're looking at blood levels. We're going to have elevated mag levels in the serum blood, decreased or absent deep tendon reflexes, muscle flaccidity, central nervous system depression, depressed respiratory rate, and depressed renal function. You start to see any of these signs, mag toxicity, calcium gluconate, we need to get this baby delivered. All right, and I think that is all I have for your antenatal slide. So we're going to close out of here, and I'm going to get ready to post this video for you guys.